Welcome to the World Congress of Neurology 2025 podcast series, the official podcast of the World Congress of Neurology, the WCN 2025. I'm your host, Dr. Stephen Lewis, and each episode of this podcast brings you conversations with the minds behind the science featured at WCN 2025. Today, it's my pleasure to be joined by Professor Sean Pittock, a renowned neurologist from the Mayo Clinic in the United States. Dr. Pittock will be presenting a plenary session on emerging immune therapies for neurological diseases, CAR-T, a fast-evolving area that may transform how we treat complex neurologic conditions. In addition to his plenary session, Dr. Pittock will be doing a number of other courses for the audience, so we have a lot to talk about today, and you're going to have a lot to learn from Dr. Pittock in Korea. Sean, welcome. It is a really great honor to have you here today.
Thanks so much, Steve. Really appreciate the invitation. I've always enjoyed the World Congress of Neurology and really excited to see autoimmune neurology getting its proper place.
And we're so pleased that you'll be in Seoul, Korea to talk about all the various aspects of autoimmune neurology. Give us a little sneak preview of the courses and plenary session you'll be participating in.
Yeah, hoping to really update all of your audience on just the exciting and rapid evolution of the field. You know, what we've seen over the last couple of decades is just an explosion in the numbers of neural antibody biomarkers of autoimmune neurological disease. These define new disorders, new syndromes. Many of them have novel and different immunopathogenic mechanisms that warrant different approaches to therapies. I think a lot of the growth has really arisen from just our significant advances in technology. You know, the old days of looking down the microscope at staining patterns of tissue and then going to mass spec and doing Western blots to try and discover what the targets are. You know, this has really evolved. And those methodologies were used, as you know, to discover a lot of the older antibodies that we all grew up learning about in medical school, like Hu, Re, and Yo. But now we actually have, you know, essentially hundreds of neural antibodies, and it makes the field really, really complex. But what's really fun is that how we've discovered many of these antibodies is through the use of, you know, technological advances, for example, like phage display, where we can essentially express the entire human proteome on the outside of a bug, and then use immunoprecipitation assays to pull down the bugs that are expressing that little piece of human protein on those millions of bugs, and then go back into the bug and figure out the DNA that then tells us what the protein is. And that's a mechanism through which we've discovered many antibodies, for example, Kelch-11, a biomarker of testicular cancer in ataxia in men, and LUZP4, and many other antibodies that are coming down the line. There's a new antibody that was discovered, CAV4, that's an antibody biomarker of a rippling muscle disease, and that was discovered using that type of technology. And then we have other technologies like, for example, using protein arrays, where you've got thousands and thousands of neural proteins in an array system, and then you can start to screen patient serums to see if they have antibodies that bind to those proteins on those arrays. So, you know, through these various and evolving different methodologies, it's very exciting. And each of these new neural antibodies that are discovered are very helpful for the clinician. And why are they helpful? Well, they're helpful for a few reasons. First of all, they help the clinician understand, first of all, what the disease is. In other words, it tells the clinician that the condition is immune-mediated. And certainly, sometimes the presence of a certain type of antibody, whether it's targeting something on the inside of the cell or targeting something on the outside of the cell, like a receptor or a channel, it kind of informs a little bit about the immunopathogenesis of that immune-mediated neurological disease. And that can direct the physician towards a specific type of therapy. Because as you know, Steve, some therapies like antibody depleting therapies, rituximab, drugs that work on IL-6 like satralizumab, drugs that remove antibody like plasmapheresis, those medications or medical approaches really help antibody-mediated diseases. Whereas when the antibodies are targeting proteins on the inside of the cell, unfortunately, those therapies don't often work well, and we need to use more chemotherapeutic type medications that hit T cells or cytotoxic T cells that are causing the damage in those situations. And in addition to therapeutic insights from the antibodies that the patients have, it also, and we'll be talking a lot about this in our paraneoplastic course that we're going to be running, it also informs about the types of cancers you want to look for in some of these patients, because many of these autoimmune neurological disorders are triggered by underlying cancers, and that can be very helpful for clinicians also.
Well, it's a very, very exciting and fast-moving field, and it's certainly hard for the clinician to keep up with it. But we do our best, and we appreciate experts like you who are not only discovering these diseases, learning how to treat these diseases, but also informing us and teaching us and keeping us abreast of all these advances that change from month to month, if not year to year. What about CAR T therapy? We are more and more institutions are performing that therapy, and we hear a lot about it, but I think neurologists still are relatively uninformed about the indications of and role of CAR T therapy.
So CAR T is just an incredible advance, obviously very much driven, as you know, by the hematology oncology world, where patients who have malignancies that previously were terminal were going to really shorten patients' lives, or in the context of breakthrough malignancies that returned or relapsed. Certainly in the hematology world, the development of a CAR T, in other words, using the concept of a cytotoxic T cell that traditionally causes disease in people, rheumatoid arthritis, and a variety of different immune-mediated disorders. The idea of taking that immunological cell that's destructive and problematic and turning it around to being something that you can use therapeutically is amazing. And there's nothing better in our armamentarium of cellular therapies for ourselves when we get a viral infection or we get a cancer, that we have this immunity, this adaptive immunity that will go and take out these infections or these tumors that we have in our bodies. And CAR T is essentially really using that approach and turning it around so that you're now actually taking and making T cells that will actually go and target cells that you don't want to exist in your body. So whether that's a cancer cell or whatever. And so then the idea of taking the concepts from using a CAR T to kill a cancer to actually using CAR T to take out specific immune cells that potentially could be causative of an autoimmune or neuroimmunological process is really a great concept, and it works. Now, what we know is that at the moment, a lot of CAR T therapies that we're using in the field of rheumatology or the field of neuroimmunology are generally targeting proteins that have been targeted before by monoclonal antibodies. So many of your listeners will have heard of rituximab. This is a monoclonal antibody that targets CD20. In the field of NMO, or neuromyelitis optica spectrum disorder, we have monoclonal antibodies that target CD19. Now, monoclonal antibodies, these do great jobs. Rituximab is a wonder therapy. In fact, as you'll know, Swedish studies have shown that rituximab is pretty much as good as any of the very expensive therapies we use in the US for the treatment of relapsing remitting multiple sclerosis. And in NMOSD, probably one of the first diseases, the first autoimmune neurological diseases of the central nervous system, where we have an FDA-approved drug, the anti-CD19 monoclonal antibodies really stop clinical relapses in NMOSD. But what we know is that the depth of the kill is potentially limited in the spleen and in the liver. Whereas if you use CAR T, you really get dramatic killing of CD20 or CD19 cells. And so CAR T really gives you an opportunity of using a cytotoxic T cell, either made from the individual themselves, autologous, or made potentially from others, but amenable to be given to anybody of any HLA status, allogenic CAR T, then the opportunity arises to use these cells to actually do a deeper kill. And the question is that better than a monoclonal therapy? Is it more long-lasting? And the concept is that if you really can use CAR T to get a really deep kill, you may get a reset of the autoimmune process. And that may be why we've seen in certain diseases like very severe lupus and other diseases, a significant reset of the immune system and even remission in some of these disease entities. So in terms of CAR T for autoimmune neurological disorders, the areas that are being worked on at the moment are generally scenarios where we think removal of and complete removal of CD20 or CD19 would be of benefit. So studies that are ongoing at the moment there are CAR T studies going on in the treatment of stiff person syndrome. There are CAR T studies going on in the treatment of peripheral nerve inflammatory diseases like myositis or inflammatory neuropathies. And there's some interest at the moment in potentially using CAR T to treat myasthenia gravis. So very exciting. Again, we need to be careful because these therapies do have side effects, and we need to be very aware of the potential of side effects from patients receiving CAR T. As neurologists, as autoimmune neurologists across the world, we are all seeing these patients because we're called when a patient with multiple myeloma or a patient with lymphoma is having a CAR T therapy and they develop a neurological side effect. And so there's a growing literature in this, and this is an area that we'll certainly cover in some of the lectures that we give at the World Congress of Neurology. But very exciting times.
Very exciting, Sean. So would it be safe to say that CAR T therapy, and I may be wrong, but it'd be safe to say that CAR T therapy is still experimental in terms of the management of autoimmune neurologic disease, or are we using it in outside of clinical trials at the present time?
Yes, a great question, Steve. Really, the answer is that it's really in research at the moment, and it's in trials. We don't have any FDA-approved CAR T therapies at the moment for any neurological disease, at least in the US. But we will see this happening. This is going to happen, and the indications for CAR T are going to expand. It's important to know that at least in the US, the FDA are quite focused on having antibody-defined entities. So, for example, with stiff person, these are the studies that are ongoing at the moment that I'm familiar with are specifically for GAD65 antibody-positive stiff person syndrome. In most trials that are currently ongoing in the field of central nervous system autoimmunity, they're antibody defined. So, for example, there are 2 MOGAD trials going on at the moment. In order to get into the trial, you have to be positive for MOG antibodies. Those trials are relating to the use of an FCN receptor inhibitor and an anti-IL-6 receptor inhibitor. And then there are trials ongoing in the context of autoimmune encephalitis, in NMDA receptor encephalitis, and in LGI1 encephalitis, again looking at an IL-6 receptor inhibitor and an anti-CD19 monoclonal antibody. But I think it is a matter of time before we start seeing CAR T trials evolve in those other areas. Because remember, if you take all of the antibodies that are associated with inflammatory brain disease, okay, only 1 or 2 diseases have FDA or approved drugs. NMO, aquaporin-4 antibody-positive neuromyelitis optica spectrum disorder. We don't have any other approved medications for any of the central nervous system inflammatory disease. So it's a great opportunity in the rare disease area for drug companies to really begin to start looking at novel therapeutics. And CAR T is going to be one of those. It's going to be, I think at the current time and in the next 5 years, it's going to be the top, one of the top players.
Well, Sean, This is remarkable. It is a very, very exciting time. I very much look forward to your plenary session, currently titled Emerging Immune Therapies for Neurological Diseases. It's a great sneak preview of it. I look forward to this plenary session and the multiple teaching courses and scientific sessions you'll be involved in. And I urge our listeners to be in Seoul, South Korea for the World Congress of Neurology 2025 to meet experts like Dr. Pittock and many others who will be there for you to meet with, learn from, and hear the real state of the art and the evolving neurological diseases, including Dr. Pittock's expertise in autoimmune neurological diseases. Any final take-home points from you, Sean? And again, I look forward to seeing you in Seoul in a few months.
No, just really looking forward to it, hoping to give very practical courses that not only cover cutting edge, but also cover just a practical approach that people can have in terms of managing and thinking about some of these really complex diseases, especially in the context of oftentimes not having access to many of these new and novel biomarkers and therapies. And so I hope that we can cover really across the board both what is available if you have access to that, and if you don't have access to that, what's a common sense, reasonable approach to take for some of these really complex neurological disorders.
Sean, thanks so much for that really wonderful intro. The idea of a practical approach for our global audience will be great, and I look forward to seeing you in a few months in Seoul, South Korea.
Yeah, and I really appreciate the invitation, Steve. I always enjoy when we meet up, and really looking forward to it.